everybody. Welcome to Fellowship Rounds, National Fellowship Rounds. So Salman Mansoor is a stroke fellow in our program in Calgary as well. He did a bulk of his training in the United Kingdom and Ireland, and has been with us now for several months. And we've actually coined him the stroke physicist in the program after this particular topic that he covered really well. And so welcome, Salman. Thank you.
Hello, good afternoon, everyone. So thank you, Dr. Demchuk. Thank you, Matthew. So my topic today is stroke rheology, the theory of everything. I'm just going to take a physics approach to stroke, as Dr. Demchuk pointed out. I don't have any disclosures to make. Yeah, so this is the outline of my presentation. I'll be going through some introduction, some basic blood viscosity principles, the Newtonian principles, plasma abnormalities, increased cellularity, hyperviscosity, and its role in stroke, different types of stroke. So coming to the definition, so blood rheology is the study of flow properties of blood, which are the viscoelastic properties, and its elements, which are plasma and cells. The relative importance of this area, which is the hemorrhagical factors and viscosity in the more common ischemic stroke subtypes, is less debated. The basic principles of blood viscosity are: viscosity, as we know from our general scientific knowledge, is the resistance to flow that arises from the friction between adjacent layers of a fluid in motion. And the formula to derive it is blood viscosity is equal to shear stress divided by shear rate. So my understanding of this formula and this equation is the center of my talk. The two dependent variables in this formula are shear stress. So shear stress is defined as the tangential force between flowing layers of fluid, and also between the fluid and the wall in which the fluid is moving. The shear rate is equal to velocity gradient between the layers of flow. So shear rate is mainly the velocity between different layers of the fluid. If we dissect the fluid, which I'm going to show you in the next few slides. From a physics standpoint, there are two types of fluids. One are the Newtonian fluids, and other ones are the non-Newtonian fluids. So the Newtonian fluids are, in simplistic terms, those fluids which kind of obey the general principles of Newton's law. And the example of a Newtonian fluid is water, which has a fixed viscosity and is independent of its flow rate, the viscosity. Whatever flow rate the water is going at, it does not depend upon the flow rate, what its viscosity would be, because it is homogeneous, the molecular binding and the atomic binding within the pure fluid or a pure liquid, kind of like static coefficient. However, the non-Newtonian fluids, on the other hand, which is the perfect example is blood, has an apparent viscosity that varies as a function of its rate. And it is this shear rate is inversely proportional to the velocity or the shear rate. So even in the equation, when I was talking about, when I was trying to derive the equation, I did mention that shear stress divided by, so blood viscosity is shear stress divided by shear rate. That means that blood viscosity is inversely proportional to the shear rate in this equation. And in the numerator, you can see the shear stress, which is directly proportional. So this is the cross-sectional diagram of a vessel lumen. And in this, you can see this parabolic shape, which is shown, is the blood which is moving in the direction towards the right. And with the liquid, you can see that in the cross-section, we have divided this liquid into different layers. You can see that the central part of the blood, it kind of like moves slightly forwards as opposed to the part which is in contact with the endothelial layer. One of the reasons are the cohesive forces which exist between the fluid itself. And the other thing, why the part which is in contact with the endothelium, why is it kind of moving slow, is the cohesive forces which are present between the wall of the endothelium and the fluid layer. So when we there are two types of shear forces or the shear stresses which exist in this diagram. One are the shear stresses or the forces which exist in between the fluid layers, and the other one is the ones which exist between the endothelial layer and the fluid surface. So, and similarly, the shear rate is this velocity difference, which is between the layers, and it can be divided by this formula, velocity difference between layers divided by distance. And the distance in this diagram is determined from this distance from the endothelial surface, and the velocity gradient is the rate at which the fluid is flowing. So the Newtonian principle, again, going to reiterate it, the ratio of shear stress to shear rate is a constant for a given temperature and a pressure in Newtonian fluids, and is defined as the viscosity or coefficient of viscosity. Newtonian fluids obey this law. The viscosity is independent of the shear rate, and the non-Newtonian fluids do not follow the Newton's law, and thus their viscosity, which is the ratio of shear stress to shear rate, is not constant and is dependent on the shear rate. Interestingly, from a physiological standpoint, there's like an interesting concept which also exists within the circulation, and this is at the level of microcirculation, which is called as Farius-Linguist effect, which was discovered by Farius, a French scientist. And this phenomena was found out that in blood viscosity decreases as the tube diameter decreases below 1 millimeter due to the reduced contribution of normal red blood cells to viscous resistance. So if you, from a simplistic sort of understanding of blood viscosity, try to gauge your, wrap your minds around this viscosity should increase as the vessel lumen decreases because of the narrowing. But in the blood circulation, what's happening is that it is inversely related due to the contribution of the red blood cells and the property of the red blood cells, which is this red cell de-shaping or fragmentability, which comes into play at these smaller diameters, which are less than 1 mm. So red cell deformability and plasma viscosity. Normal deformability allows erythrocytes, which are a diameter of 8 micrometers, to squeeze through capillaries, the diameter of 4 to 6 microns. Normal deformability requires sufficient ATP. So in states where ATP is depleted, this property of the circulating blood is compromised, and you would find it would become more difficult for the red blood cells to pass through these smaller vessels in case of ATP depletion. And examples are trauma, burn, sepsis, etc. So red cell aggregation, it's a reversible process that causes most of the Newtonian flow behavior of whole blood. There are large electrically positive macromolecules in the plasma, mainly fibrinogen, globulins, which facilitate this bridging and reduces the electronic repulsion between the red blood cell. So fibrinogen actually has this, it's the main contributor when it comes to different plasma proteins to sort of like contribute to this property of the blood. And in states where there is elevated fibrinogen and paraprotein levels, they cause an increased erythrocyte aggregation, which is kind of like a more suitable environment for this clot formation. And the conditions, as I stated earlier, are trauma, shock, burns, infections, complicated diabetes, malignancy, and rheumatic diseases. This is more sort of like a detailed list of factors which are influencing this blood viscosity that include hematocrit levels, plasma proteins, fibrinogen concentration, cellular aggregation, red cell deformability, vessel diameter, flow rate, leukocytes, and platelets. There are certain low shear rate states in which the viscosity increases logarithmically at the low shear rates, and this effect is magnified at high blood cell count and increased concentration of plasma proteins. Low flow, such as high-grade arterial stenosis, is an example, or a systemic hypotension or a hypovolemic state increases the blood viscosity based upon this associated low shear rates. This results in this reduction of inflow and potentially leads to this vicious cycle, which kind of like leads to aggregation of blood cells, stasis, and favoring of the thrombus formation. So the hyperviscosity states are mainly divided into these types: diseases that causes increased protein levels, increased cellularity, decreased red cell deformability, and covert hyperviscosity states. So these are few of the examples and the evidence which supports these states. So hyperproteinemia, there was a meta-analysis which was done on 31 prospective studies, and it was published back in 2007. It was a meta-analysis of association of plasma fibrinogen levels with established cardiovascular disease risk factors, inflammatory markers, and other characteristics. In the individual participants which were included in this study were around 154,211 patients. And what they came to a conclusion on was that the risk of stroke increased for each 1 gram per liter increase in fibrinogen levels. Age and sex adjusted hazard ratio was calculated to be around 2.06 with a confidence interval of 1.83 to 2.33. And after regression analysis and adjustment of several established vascular risk factors, this hazard ratio came out to be still very high, which was 1.8 in this meta-analysis, which supports this hyperproteinemic state and blood viscosity theory. Second thing, another example of hyperproteinemic state comes from an indirect evidence in iatrogenic IVIG infusions. So we know that in IVIG infusions, there is a higher risk of stroke in the early few days. And it sort of like it correlates directly to the amount of IVIG infusion being given. And the time duration from which the IVIG infusion is given. So this was a study which was published in Basic Science Review, which looked at the effect of high dose. Looked at the effect of high dose IVIG therapy on blood rheology, and the concentration of IgG infused correlated strongly with viscosity of plasma and whole blood in vitro and vivo both. And this supported this theory as well. Increased cellularity, which is the second mechanism, and increased cellularity is indirectly assessed by with hematocrit. This was another study which was published by Togi et al. On 432 consecutive patients with cerebral infarction at autopsy, and found that the risk of ischemic stroke rose dramatically for a hematocrit value which was greater than 46%. That supported the theory. Increased cellularity also is seen in polycythemia vera. There was an interesting article which was looking at the efficacy of safety of low-dose aspirin in polycythemia vera. And it found out that the major risk of cerebrovascular events were around 3.8% in people who were not taking any antiplatelets, as opposed to 1.2% who were on antiplatelets. However, I quoted this reference just to get a sense of incidence in polycythemia vera due to increased cellularity in this paper. Increased cellularity, the same mechanism also implies in AML. There was a study which looked at these epidemiology and clinical association of stroke in patients with acute myeloid leukemia. And they reviewed around 10,972 admissions from 2012 in national inpatient sample in the United States. And there was a 50-fold increase in the risk of stroke in active AML patients compared with all the rest of the admissions in an inpatient hospital setting. And this risk also increased further if these patients with AML had sepsis or a concomitant condition, which would increase the blood viscosity. The third mechanism, which is the decreased red cell deformability, it kind of like governs these, for example, these three states, which are sickle cell disease, hereditary spherocytosis, pyruvate kinase deficiency. For reference, in the sickle cell disease, this was an interesting study which was called the cooperative study. This was looking at cerebrovascular accidents in sickle cell diseases. They were looking at the rates and the risk factors. In the cooperative study, what they found out was that the sickle cell disease trait had this prevalence of 4.1% for stroke and TI or major or minor cerebrovascular accidents. Other covert hyperviscosity states, including diabetes, inflammation, atherosclerosis, systemic low flow hemoconcentration states like burn injury, inappropriate red cell transfusion, dehydration, or circulatory shock. It's fascinating that how these can be so much interconnected when we are looking at blood rheology and stroke at the physics level. So in smoking, hypercholesterolemia, diabetes, and obesity, there are theories which support that the blood rheological factors are increased. And in the hypertensive state, what's different is the velocity, which is the shear rate. It is different. And if the vessel lumen, in cases when there is an arterial stenosis or a luminal lesion or a luminal problem, there is this turbulence flow which causes these oscillatory vectors within the flowing blood, which causes an increase in atherosclerotic plaque and also kind of like contributes to rupturing of this atherosclerotic plaque and causing strokes. So these were the few mechanisms. Now I'm gonna discuss role of hyperviscosity in ischemic stroke subtypes, how this theory also stands true. So this was a paper which was published from Germany about the hematological factors of lacunar stroke. In a study of 40 patients with lacunar strokes, they confirmed by clinical and radiological criteria that erythrocyte aggregation, erythrocyte deformability, plasma viscosity, fibrinogen concentration, and shear stress are pathologic when compared to those of normal control patients, but they were not able to find hematocrit as significantly different. This was another paper which was also published in Basic Science Review, which looked at the arterial wall shear stress observations from bench to bedside. And what they found out in that study was that atherosclerotic lesions typically occur in regions of low shear stress, which from a cellular point of view appears to accelerate the endothelial proliferation in those with beds, shape change and apoptosis, and increases the secretion of factors that promote vasoconstriction, coagulation and platelet aggregation. So this was a 2003 paper. This was a paper which was published by Lee et al., and it was looking at blood viscosity and elevated carotid intima media thickness in men and women. It was from the Edinburgh group, and what this study found out was that a hyperviscosity seemed to contribute to carotid atherosclerosis pathogenesis. A longitudinal cohort study found that blood viscosity, plasma viscosity, fibrinogen, and hematocrits were all linearly related to the carotid artery intima media thickness in men, mainly, which also supported carotid atherosclerosis, closely related to this blood rheological concept. This is a diagram which shows this high shear stress at an area where there's like a tightening, and as the tightening resolves, there's like this low shear stress in vascular beds which are following. The lipid core in the vascular beds, which are just adjacent to this high arterial stenosis bed, are kind of more prone due to the lower shear stress, which kind of like increases the apoptosis and the proliferation in these vascular beds and causes this plate formation.
Just a 5-minute warning, okay?
Yes. So this concludes my talk. This is a saying by Lau, who says that those who flow as life flows know they need no other force. And blood viscosity is equal to shear stress by shear rate. This is the basic summary of my talk. I'm happy to answer any questions.
Wonderful. Thanks very much, Salman. That was great. Lots of good physics for us, reminding us about shear stress and viscosity. I guess one of the questions I would have is, I don't routinely order fibrinogens, and I don't often look for some of these paraprotein, conditions. What sort of clinical situations should I be alerted to where I need to be thinking about those sort of tests?
Yeah, so that's a very good question, interesting question. So what we are not looking, so this is sort of like looking at stroke as in more absolute way as opposed to as in static terms. So blood viscosity, rheological factors, all these vectors and forces, they probably have this cumulative sort of like risk of causing all these different strokes. I wouldn't say that one factor is absolutely the one factor which you would be able to pinpoint at. When it comes to blood rheology, you can actually explain any sort of stroke mechanism based on this theory. If you would be able to look at stroke in a more dynamic way in some way in future, then probably this would encompass all these different variables, including fibrinogen, plasma proteins, lipids, diabetes, everything, and what their effects are on blood viscosity. Probably that would kind of make a good probabilistic probability that somebody might have a stroke if somebody has a blood viscosity like this at this particular given time, that this person has this blood this sort of like stroke risk in the future. So
I guess the question, another way maybe to look at the question is, if you've got a patient who's behaving unusually, having recurrent events despite lacunar syndrome or something like that, should we start looking at fibrinogen and any of these other sort of things that might be contributing in addition to the risk?
So, for example, in our practice, we look at these occult malignancies as sort of like an indirect ways to look at D-dimers or fibrinogen levels to see whether they are high or not. Septic states, and specifically when I was quoting that AML paper, in those sort of situations, there is something definitely treatable. There's like a hyper cellular state. So yes, blood viscosity, measuring that in those particular states when you're thinking of ESIS-related strokes or strokes which are related to a focal malignancy that that don't have any good explanation. So I think blood viscosity measurements and these other factors can definitely contribute to to solving this diagnostic dilemma.
Is there any therapy that can lower fibrinogen that we really have? Is there, like, some of our current medicines have small effects on lowering fibrinogen?
So, to be honest, I don't know the answer to this question, but
there are two, Salman. There are two known, right? Well, one is alteplase, right? Because it does result in deeper, and another one that's not used so much anymore because we have now fondaparinux and argatroban associated with HIT, but that's Ancrod, which is a pure defibrinogenating agent, right? Ancrod is Malayan pit viper venom, right? Which of course, if you get bitten by a Malayan pit viper, then you typically bleed to death. But if you use it in in appropriate concentrations, it used to be used widely for people who had frostbite as a treatment, and then also people who had HIT associated with heparin. And it was because before we had alternates to heparin. So, cardiac valve patients who developed heparin-associated thrombocytopenia, you could give them Ancrod to help manage anticoagulation, get them through so it's there. And the other thing I would just point out for everyone on the call is that some of the first or the earliest acute clinical trials in stroke were done with agents which were designed to reduce viscosity. So infusions of dextran and others. There were several studies done in the late 1980s, randomized trials, with the idea that improving blood rheology would result in better outcomes in acute stroke. None were effective, of course, but they are there in the literature.
Yeah, there was one study with dextran used post-endarterectomy to prevent emboli, which was positive in terms of, so there may be some effects on active embolization with dextran. It was an Australian study, but that's about the only one I've seen that had some clinical effect. But I agree completely, Michael. It's we don't really have a prevention strategy that we can take daily that impacts the fibrinogen. All right. Any other questions? We're coming up on the hour. I just want to leave a minute or two if anyone else had any questions. Just put it in the chat box. Good. Okay, I guess not. So well, thank you very much, Salman. That was just excellent, really good detail on all of these things that we as stroke neurologists need to learn more about as plumbers and flow. And so thank you very much for your time. Also thank Matthew, and I hope everyone has an excellent rest of their day and weekend.